That's where the prominence of the cheek is. A lot of people call them cheekbones. Your mouth and lips, cheeks, chin, and external ear. And if you look in your Kindle, they'll identify the different landmarks. Of course, letter A shows the face at rest, and letter B shows the face smiling. Now, the different features of the face, again, it really helps, especially when we're doing x-rays. So when you guys come to lab and it's time to do x-rays, I'm going to point out a lot of the landmarks so you guys take excellent x-rays. Now, excuse me. Some of the facial features are outer and inner canthus of the eye, ala of the nose, the philtrum, the tragus of the ear, the nasion, glabella, the root or bridge of nose, the septum of the nasal cavity, anterior nares of the nostril, the mental protuberance of the mandible, the angle of the mandible, and the zygomatic arch. And again, please look at your Kindle so that way you know all the things that were listed. Our main region that we usually work on is, of course, the mouth area, the lips, the cheek area. When I take x-rays, I kind of use the corner of the eye, okay? Sometimes I use the corner of the nose, depending on the angle of an x-ray that I'm taking, because certain teeth, and we're going to be talking about this in a chapter or two later on, certain teeth are like right below the eye. Certain teeth, like your canines, are right about here. So I really use the corner or the inner part of the nose here to do my landmarks. And I even use the hairline. I don't go further than the hairline because this is where, and if you remember yesterday, we talked about the mandible. The TMJ is right about here where number 5 is. So there's not going to be any teeth right there. So I want to make sure that when I'm taking x-rays, I don't go past the hairline because now we're choking the patient. Um, and just to make a point, just so you guys know, if someone has this many earrings on when you're taking x-rays, unfortunately, you're going to have to tell them that they have to remove it because they will mess up your x-rays. So just something that I just saw there, and I wanted to point out to you guys. Now, the skin of the face is thin to medium in relative thickness. It is soft and movable over a layer of loose connective tissue. The skin around the external ear and the ala of the nose is fixed to underlying cartilage, and facial skin contains many sweat and sebaceous glands. Now, believe it or not, I'm going to come back to this, girl. The skin is very important to us also when we are picking a shade of a tooth. So, for example, if you have a patient that has no teeth and they want dentures, well, what are you going to use for reference? You can't use any other teeth because they have none. So you start kind of picking a shade that is a little bit lighter than their skin tone. So that way it can blend in. If someone picks white teeth, then you know they're fake. So, and you are going to have patients that no matter what you say, they want those bright teeth looking dentures. But someone that says, no, I don't want nobody to know that I have dentures, then again, you use their skin and you match the shade. And again, when we're in the lab, I'll help you do that. Now, the lips is also known as the labia, and outline there's a vermilion border. The labial commissure is the angle at the corner of the mouth where the upper and lower lips join. The nasolabial sulcus is the groove extending upward between each labial commissure and the ala of the nose. So right around here. So ladies, when we put liner, you're putting it on the vermilion border. Your philtrum is right in the middle. That's that little kind of dip that you have in front of your lips. And of course, you know the lower lip and the upper lip. Now, inside the vermilion zone, everyone's is a little bit different, but that's that pink sort of kind of color that you have on your lips. And the labial commissures, again, is right here at the corner. Now, the oral cavity is lined with mucous membrane tissue, and it consists of two areas. The vestibule is the space between the teeth, and the inner mucosal lining of the lips and cheeks, and the oral cavity proper is the space contained within the upper and lower dental arch. The vestibule begins on the inside of the lips and then extends from the lips onto the alveolar process of both arches. The vestibular mucosa is thin, red, and loosely bound to underlying alveolar bone. The base of each vestibule where the buccal mucosa meets the alveolar mucosa is called the mucobuccal fold. And the mucogingival junction is a distinct line of color change where the alveolar membrane meets with attached gingiva. And if you remember from yesterday, we're hearing that word buccal again. Buccal is the side of the surface. So these teeth over here that they're showing that you can see on the side, these are the buccal surfaces towards the cheek. Okay. Now again, on your Kindle, please take a look so you know exactly where to find. This is the frenum. You can actually right now, if you put your tongue up to the front of your teeth in on the maxillary, you're gonna feel like a tag of skin there. That is your labial frenulum or frenum. Okay, some people have really pronounced ones and some have a light one. It all depends. Everybody's a little bit different. And then here on the bottom, here's your buccal vestibule. Again, these are the surfaces closest to the cheek. Now I'm going to point out something just because I see it. These teeth are really yellow, as you can see, and then in the back, they're a little bit lighter. This really looks from poor oral hygiene, lack of brushing. Also, I see a lot of cavities. That's the brownish stains on them. Some of them are stains, but some of them are actual cavities. Especially the one over here, if you look at my arrow, there's a molar. We're going to get into this a little bit later. These are called class 5 cavities. They're cavities at the gum line. Class 5 means at the gum line. And we'll get into a little bit more when we get into that chapter. But I wanted to point it out because this person has a lot of them. Here's another one on the opposite side on the lower. That brownish on their teeth, that's cavity. This yellow stuff that's on this canine over here, this is plaque. It gets hard. And after a while, you can't remove it with your toothbrush. And the hygienist would have to remove it, whether with her Cavitron or scaling or whatever instruments she uses. But I wanted to point that out to you guys. Now, this is called the Linea Alba, where the arrow is pointing, okay? Some people have that very pronounced and some people don't. No big deal, you know, but everybody has one. Labial and other frenula. A frenum is a narrow band of tissue that connects two structures. So I pointed that out to you right here, okay? So it is connecting the right and the left together. It passes from the midline of the maxillary or mandibular arch to the midline of the inner surface of the lip. The buccal frenum passes from the oral mucosa near the maxillary or mandibular first molars to the inner surface of the cheek. So coming back to this one, here's the buccal one. Okay, so this is what holds the cheek together with the mouth. And the gingiva, commonly referred to as gums. Some people refer to it also as tissue. So gums, tissue, gingiva, all the same thing. Are masticatory mucosa that cover the alveolar processes of the jaw and surrounds the neck of the teeth. And it looks like this. So there's different parts of the gingiva. We have what's called the marginal gingiva. So that's right at the margin of the tooth here. Okay, so a lot of times when the doctor is doing a crown, he comes right up to the margin. So you don't see the space in between the actual tooth and the crown. We have what's called the attached gingiva, that's above here. And we have the interdental gingiva. Interdental means in between. Inter is in between where you would normally floss. Okay, this is a real good picture to see the mandibular buccal frenum. So right here, here's another frenum right in the front. So not only does the maxillary have one, the mandibular have one, the lowers have on the side, just like the top. This person has a couple of frenums. So again, everybody's a little bit different. They have like, this person has like, woo, 1, 2, 3, 1, 2, 3, and then the one in the middle. So they have 3 on each side and the one in the middle. On the bottom, they have this one and then 1 on each side. Any questions before I move on? Okay.
Yes.
Yes, I'm
Why
listening.
is an eye some yellow and another teeth have another color?
Canines are usually the most yellowish because they're the most bulkiest of the teeth. And because they are so bulky, they have the most dentin. So canines are always usually a little bit more yellower than all the rest of the teeth. Good question. Anybody else with a question? All right. So characteristics of normal gingiva. So when you get a chance after lecture, please look at your gums, okay? You want to make sure that normal gums or gingiva surround the tooth like a collar and are self-cleansing. They are firm, resistant, and can be tightly adapted to the tooth and bone. The surfaces of the attached gingiva and interdental papilla are stippled and similar in appearance to the rind of an orange. Surface colors varies according to the individual's pigmentation. So here is gingiva on a lighter person's skin tone, and here is one on the darker. Now, of course, on the darker, if you look on this person's gums, you can actually see what they mentioned about the gums have that little look to it like an orange peel, like it's stippled. It has those little holes. That's what it means, okay? Is there something wrong with it? Absolutely not. It's just the way it is, okay? That's how the gums are. Now, how do we want to make sure our gums are healthy, that they're not bleeding, that they're covering our tooth to the margin, that they're tight around the tooth, they're not loose and flappy. We want to make sure we're flossing because food tends to get stuck in the middle, and what ends up happening is, for instance, here's excuse me, here's a great picture. You see where my arrow is, there's some brownish going around some of the teeth. Some of it is stain and some of it is cavity. So we also want to make sure, come to letter A, notice how the gum is all the way up here. Okay, so it is really nice and tight on the collar of the tooth. But notice on letter B how the gum dips. Now the gum starts dipping because if you look real closely, there is what we call calculus on the teeth. Calculus becomes hard like a rock. And when it becomes hard like a rock, you can't remove it. Again, I mentioned plaque, calculus, stuff like that. The hygienist can remove off your teeth. When it becomes hard like a rock, it's very hard for you to remove it unless you have the instruments to use, but then you don't want to hurt your gums. So what happens with the gums is they pull away from the calculus and they start what we call receding, because the gums are like, I don't know what this is, I don't like it, and they start receding or bleeding. Now coming up here to this tooth, if you see my arrow, that's another cavity. So this right here tells me that the patient is not doing a really good job brushing their teeth, especially at the gum line, because they're getting a lot of cavities, a lot of stains, and they're not flossing because their gums are starting to recede, and also it's starting to create spaces. So I wanted to point that out. Now this is another close-up picture. So this is super healthy, okay? If you look at the gums, there's that stipple look. You want to make sure you floss. You bring in the floss one way, come all the way down to until you meet some resistance. You wrap it around the tooth, you come back up and you come to the other tooth and you wrap it around, and you make sure that whatever is stuck here in the gum, you get it out with floss, and you continue doing that throughout your mouth. Now, unattached gingiva is also known as marginal gingiva or free gingiva. is the border of the gingiva surrounding the teeth in collar-like fashion. It consists of the tissues from the top of the gingival margin to the base of the gingival sulcus. The unattached gingiva is usually about 1 millimeter wide and forms the soft wall of the gingival sulcus. So when someone has gingivitis, the unattached gingiva is the first tissue to become inflamed. So it starts becoming red, it starts bleeding a little bit, and it actually starts hurting. Interdental gingiva, also called gingival papilla, that's the extension of the free gingiva that fills the interproximal embrasure between the two adjacent teeth. So coming up to here, again, this is what they're talking about. Interproximal, interdental, all means in between. Now, the gingival groove is a shallow groove that runs parallel to the margin of the unattached gingiva and marks the beginning of the attached gingiva. And the attached gingiva extends from the base of the sulcus to the mucogingival junction. The oral cavity proper is the area inside the dental arches. In back of the last molar on each side is a space that links the vestibule and the oral cavity proper. Your hard palate separates the nasal cavity above from the oral cavity below. The nasal surfaces are covered with respiratory mucosa, and the oral surfaces are covered with oral mucosa. The mucosa of the hard palate is tightly bound to the underlying bone, and therefore submucosal injections into the palatal area can be extremely painful. So yesterday I mentioned to you the palate is on the top of the mouth, and a lot of you refer it to as the roof of the mouth, and it is the palate. You might hear it palatal, maxillary palate, so roof of the mouth. Now, the landmarks of the hard palate, the incisive papilla is a pear-shaped pad of tissue that covers the incisive foramen. The palatal rugae are irregular ridges of masticatory mucosa extending laterally from the incisive papilla. So if you put up your tongue to the roof of your mouth, you might feel some ridges. Those are the rugae. The palatine raphe runs posteriorly from the incisive papilla at the midline, and the palatal glands are numerous small glands that open onto the palatal mucosa as small pits. We also have a soft palate. It's the movable posterior third of the palate. It has no bony skeleton and hangs like a limp curtain into the pharynx behind it. The soft palate extends posteriorly as a free edge with a hanging projection called the uvula. And I'll be showing you pictures in a second. The soft palate is supported posteriorly by two arches, the fauces. The anterior arch runs from the soft palate down to the lateral aspects of the tongue as the palatoglossal arch. The posterior arch, the free posterior border of the soft palate, is called the palatopharyngeal arch. The opening between the two arches is called the isthmus of fauces and contain the palatine tonsil. So if you look here, so right over here on the top of your mouth, and again, you can look in the mirror later to see yours. Okay, so on the top, what we call between 8 and 9 or the midline, you're going to find on the lingual portion of your mouth, that's the inside. This is called the incisive papilla. Now, sometimes, I don't know if you've ever eaten something sharp like a Dorito, and all of a sudden you feel like this swell up because you might have injured it. It's very sensitive. And then these lines over here, palatine rugae, okay, these lines, some people have them very prominent. Some people have them flat. It all depends. Everybody's a little bit different. And again, this, even though this is the roof of the mouth, but this surface here is closest to the tongue. So this surface is called the lingual. And again, we'll get more into the surfaces, but I want to start pointing those out to you. Now, down the middle, you see a fine line going down the middle. Those are the medium palatine raphe. And it's hard to really see them, but there's ducts for the palatal glands. Now, I will say this, if you do take an impression of the upper, you have to make sure that you get the palate real well. The lab guy, especially for dentures, He wants to see all this, the incisive papilla, because if somebody doesn't have any teeth and you're taking impressions, he needs to know where this incisive papilla kind of helps him to establish where he's going to put 8 and 9 on a denture. Also, he has to make sure that the denture fits this palate, so he kind of makes the grooves the same so the denture kind of locks into place. Now, the hard palate is the front part, and the soft palate, notice the difference a little bit in color. So this is really pink, and then this comes a little bit lighter pink in the back. The lighter pink area is the soft palate. So that's the part where if you hit it with the mouth mirror or suction, you make the person gag because it's soft and it gives that instinctive to like for the patient to want to throw up or gag. So be careful hitting the soft palate. In a case like this, also, when you take impressions, you want to make sure that you take all the teeth, so all the way up to the back of the tooth, okay? And then here, this is the surface features of the soft palate. So again, here's the lighter color of the soft palate that has this, what's called a uvula. Now, a lot of people say that's my tonsils. It is not your tonsils, it's the uvula, okay? And then here on the side, it's very hard to tell, but these are where your tonsils are. So they're like little projections on the side. And there's some down here near the tongue, the base of the tongue. It's really hard to see those, okay? Now the tongue, it is an important organ. It's responsible for several functions like speech, manipulation, and positioning of food, sense of taste, swallowing, and most importantly, cleansing of the oral cavity. Now, the tongue, the top of it is covered with a thick layer of mucous membrane and has a lot of thousands of tiny projections called papillae. We're going to talk about that in a second when I get to the tongue. Parts and surfaces of the tongue, you have the body, anterior 2/3 of the tongue, the root, posterior portion that turns downward toward the pharynx. So that's in the back. The dorsum is the upper and posterior roughened surface. The sublingual surface is covered with smooth, transparent mucosa. And then you have the lingual frenulum. That's the thin fold of mucous membrane that extends from the floor of the mouth to the underside of the tongue. So here is the dorsum of the tongue. Dorsum is the top, okay? Now I want to point out something to you. And again, please look at this after lecture at your tongue. If there's this little coating on it, you can see like it's kind of yellowish. That means you're not doing such a great job brushing your teeth, brushing your tongue. You really want to brush your tongue because what happens is when you don't brush your tongue, this little yellow covering starts turning different colors. It eventually, once you don't get it off your tongue, it starts turning brown and then it starts turning black. Now, we just finished talking about that the tongue has papillae. Papillae are little fine hairs. You can't see it as much if your tongue is clean. But if your tongue is dirty and you look real close, you can see the fine hairs on it. When you leave your tongue for a long period of time of not cleaning it, you get something called black hairy tongue. And your whole tongue turns black and you can see the hairs, like hairs on your eyebrows, nose, things like that. It's so gross. And the only way to remove that black hairy tongue is to actually shave it. Yes, shave it with a razor. Okay, so don't let your tongue get like that. And we will have lecture on black hairy tongue. But if you want, please look it up after lecture so you can keep that picture in your head and never let your tongue look like that ever. Now, here's the sublingual aspect of the tongue. So here is that lingual frenum. Okay, so remember we talked about frenums on the buccal side. Now this is the lingual side. All right, and of course, you know the tip of the tongue. Yesterday we talked about the sublingual caruncles. All right, so they're right over here. And of course, you can see the veins on your tongue too when you lift up your tongue. Now you have some taste buds and they're located on the fungiform papillae and in the trough of the large valid papillae, which form a V on the posterior portion of the tongue. The sense of touch is provided by numerous filiform papillae that cover the entire surface of the tongue. The teeth are either single-rooted or multi-rooted, and we are actually going to have a lecture all only on teeth soon, so you don't want to miss that. The teeth sit in bony sockets or alveoli within the alveolar process of the maxilla and mandible. In the mouth, a cuff of gingival tissue surrounds each tooth, and the portion of the tooth that's visible in the oral cavity is called the crown. Okay, so I've already pointed out several surfaces to you, and we're gonna go more into that. And the teeth that you see, these are called the crowns of the teeth. Only that portion, the part of the tooth that we don't see that's in the bone is the root. But again, we'll go more into that, including surfaces, the numbers of the teeth, and things like that in a few more chapters. We'll get into it a little bit more. Any questions on this chapter before I move to the next one? No questions? All right. Let me find the next one. Can you guys see chapter 24?
Yeah, we can see it.
Okay, thank you. All right, so again, please read your objectives. So now we're going from teeth to waterlines. Now, you're going to see how important this lecture is, because you're going to be like, Ms. Perez, why do we have to talk about this? We have to talk about this because we use waterlines in the office a lot. And with the things that are going on right now, like the pandemic, the last thing we need is to have any type of waterborne diseases in our office, our laboratory, our facility, wherever you're working at, or even in our school. Okay, so there have been outbreaks of waterborne diseases. We're going to talk about that. Published reports. Bacteria is capable of causing disease in human beings that are found in DUWLs, and we're going to talk about DUWLs is your dental unit waterlines, which is reason for concern. Now, the CDC, and I know you've heard that word a lot now through the pandemic, recommends that dental water meet the same standards as drinking water. So this is what a close-up look of our dental unit waterline looks like, okay? So this part right here is the hose. All right. And we have this little nozzle that connects to our handpieces. And where they're showing the arrow, that's where the water line comes out from. Now, there's something called biofilm. Biofilm is dental plaque, okay? We want to make sure that we don't have any of that. Somebody had a question? I'm sorry?
I can't see the picture. I mean that they made.
You can't see the PowerPoint moving?
No.
Is that for everybody else?
Yes.
Yeah, I can see it.
Yeah, but do you see the PowerPoint moving?
No.
Okay, give me a second. Okay, can you see the PowerPoint now?
Yes.
Is it moving?
Yes.
Yeah.
Okay. Thank you for letting me know. But now it came out a little bit smaller and I can't make it bigger. So I hope you can see it. This is the picture that I was saying that it is the hose for the dental unit waterline. And this is the connector that we connect the handpiece on. Now, I was saying, if you see these little arrows where that's where the water line comes out from. And there's something called biofilm that we don't want on our teeth because it causes dental plaque. And so we're going to get a little bit more into that. So in community water, the number of waterborne bacteria is kept to a fewer than 500 colony forming units, that's CFUs per milliliter. There's water from air water syringes and dental handpieces. They have bacterial levels hundreds or thousands of times greater than those permissible in drinking water. The types of bacteria that are found in dental unit water are frequently the same types found in community water, but levels of bacteria in the dental units are almost always higher. Now, for the new students, when you come into the lab, I will show you even again where the water lines are. For the older students, if you remember, we did a thorough cleaning of the tubings of the water lines before the pandemic hit and we didn't go back to lab. So hopefully you remember that. But if not, this is a great refresher course, okay? So dental healthcare workers are exposed to Legionella bacteria at a much higher rate than are members of the general public. Dental personnel are exposed to contaminated DUWLs through inhalation of the aerosol generated by the handpiece and air water syringe. So this is why it's important for us to wear our mask at all times. So at least one suspected fatality of a dentist resulting from Legionella has been recorded. Published case reports have described immunocompromised patients in whom postoperative infections develop as a result of contaminated dental water. So what has happened is when we have surgical procedures, we no longer use the water, no matter how clean it is, from the dental unit water line. We usually use what's called sterile water, where we purchase it and use it straight from the bottle instead of the dental unit water lines, because once we do an extraction or any type of surgical procedure, the patient is prone to infection. So the last thing we want to do is to add on to any infection by using any contaminated water. Now, there are microorganisms in dental unit water, and the primary source of microorganisms is the public water supply. Saliva can be retracted also into the DUWLs during treatment, which is called suckback. That's from when we are giving the patient the saliva ejector. That usually takes out the saliva, but if the patient is sucking on the saliva ejector like a lollipop, usually the saliva tends to reverse back into the system. So anti-tire traction valves on dental units and thorough flushing of the dental lines between patients minimize the chance of the suckback. So in other words, when the patient is finished, we like to clean the water lines. The public water source has a CFU count of less than 500 milliliters before entering the DUWLs. And once that water enters the DUWLs and colonizes within the biofilm, the CFU count skyrockets. So how does biofilm? I said biofilm is dental plaque. And there's different types of plaques when we talk about plaque on the teeth and plaque in the water. But plaque is no good regardless. When we talk about plaque, plaque is no good. We don't want plaque. So biofilm in the plastic tubing, it serves as a reservoir that dramatically increases the number of free-floating microorganisms in water. In other words, we have these little valves inside the dental unit lines to help prevent that. The source of microorganisms, there are two communities of bacteria in DUWLs. One bacterial community exists in the water itself. It's called planktonic, free-floating, and the other exists in the biofilm attached to the walls of the DUWLs. Now, if we had biofilm in our tubing and we did this microscopic magnification of it, it would look like this. It's pretty gross. Okay. Again, just so you guys know, when the pandemic happened and we had to clear the lab, I myself and my other instructor, that's also, her last name is Perez too, we went into the laboratory and we basically bleached the whole lab. We use Clorox, bleach, you name it. And we also put it in the lines and we let it sit there for a couple of days. So if there was any biofilm, it can be clean. We also have to do it on a continuous basis. So when you guys come back, it will be a perfect time for us to redo it again. So then that way we don't have any biofilm in the hoses. Now, biofilm exists in all places in which moisture and a suitable solid surface are found. It consists of bacterial cells and other microbes that adhere to surfaces and form a protective slime layer. Excuse me. If you guys have a garden hose and you leave it with water and you go to that garden hose and you kind of feel it and it feels slippery, that's that biofilm. Okay. And that goes for anything in your house that you might have had a hose for, and moisture gets in it, darkness, and it can create not only biofilm, but as we're going to talk about here, many types of bacteria as fungi, algae, and protozoa. And viruses such as the human immunodeficiency virus cannot multiply in DUWLs. That's HIV for those of you that not sure about that. Now, the biofilm in dental water lines. At the dental unit, the water enters plastic water lines, which pass through a multi-channel control box that allows the water to be distributed to the hoses that feed various attachments, such as our high-speed handpiece and air water syringe and ultrasonic scalers. The DUWLs have a narrow tube, and biofilm forms on the inside of the DWLs as water flows through the unit. Then growth promoting factors. There's several factors that contribute to the formation of biofilm in DUWLs. Water moves at a normal line pressure, which means slowly. Intermittent stagnation of water inside the units typically occurs between patients overnight, over weekends, allowing planktonic communities of bacteria to attach to the walls of the tube, and the bacteria become stabilized on a surface, and the nutrients in the water feed them. So usually in the morning, let's say you don't work on the weekends and you come in on Monday morning, before you attach anything to any of the hoses or the air water syringe line, you want to run the hose. So if any stagnation water is left in the unit, it comes out first instead of you squirting it in the patient's mouth first. Again, if we had a microscopic magnification of our biofilm, this is what it would look like. Now, the characteristics, the bacteria embedded in the protected biofilm, that slime layer, are extremely difficult to remove or kill. Bacteria in the biofilm are up to 1,500 times more resistant to chemical germicides than our planktonic, that free-floating bacteria. During use of the dental handpiece or air water syringe, some bacteria already present in the incoming public water, as well as bacteria dropping off the biofilm, are carried out. So again, this is why I tell you guys, make sure you run the lines first before you squirt any water in the patient's mouth. And that goes for anything that squirts out water, whether it's the hand pieces, the air water syringe, or even the eye wash station that we use for our eyes to clean our eyes. If something falls in our eyes, you don't want to leave the eye wash station, and we'll talk about that more, of course, later on. But you don't want to leave the eye wash station without at least turning it on once daily or every couple of days to make sure that there's no stagnant water. God forbid you get something into your eye and you go to the eye water station and you throw water in your eyes. The last thing you need is bacteria in your eyes too. So we always have to keep everything extremely clean. Now, the methods for reducing bacterial contamination. Again, it is not yet possible to eliminate it, but it can be minimized. So self-contained water reservoirs, we have that. Chemical treatment regimens, we have that. Microfiltration, we have that also. And daily draining and drying of the lines. And hopefully, when I teach you guys are doing everything correctly, so we don't have this problem and we're not causing any excessive biofilm. Now, self-contained water reservoirs are supply air pressure to the water bottle. Air pressure in the bottle forces the water from the bottle up into the DUWL and out to the handpiece and air water syringe. The self-contained water systems have two advantages. Dental personnel can select the quality of water, and the maintenance of the water system between the reservoir bottle and the handpieces and syringes is under the control of the dentist and the staff. So here is a picture of it. So if you guys look right here where my arrow is, this is a self-contained bottle. In our lab, in our school, okay, we use the bottle with the hose in it. Now this one is clear. These, by the way, are those hoses that I told you that the water comes out. If you guys see these hoses right here, this is our handpiece that connects to the hose. So when we turn it on, the water flows through here and comes out through the hoses. Now our bottles look like this, okay? They have a hose. You barely can see the hose, but they have a hose that goes into the bottle. Now, here's the other thing I'm going to tell you guys. Never fill up a bottle with water already inside of it. If you have to fill up a bottle, what do? You empty the old, clean out the bottle, and then put new water inside. Never mix the two together, because you want to make sure every time you, because a lot of people, they're like, I'm going to fill these bottles, but instead of throwing away the old water, they just replenish it to tap it off. You don't want to do that. You want to get rid of the old. You want to put new water in here. And I'm going to see if I have pictures still in my phone, because I had to clear up my phone. I was taking pictures of all these, but then it got so overloaded, I had to delete a lot. I'll see if I still have the picture of these little tiny tablets that we use to filter our water. So we use tap water, and then we put a tablet, we drop it in here, and it helps filter the water, go through the hose and into the water line. So I'll look for it and see if I still have it. Now, the microfiltration cartridges, disposable inline microfiltration cartridge can dramatically reduce bacterial contamination in dental unit water. The device must be inserted as close to the handpiece or air water syringe as possible. The use of filtration cartridges combined with water reservoirs ensures improved water quality, and cartridges must be changed according to the manufacturer's recommendation. So they're connected to the hose, and then they go inside the water bottle, okay? Now, by the way, the hoses is what gets that biofilm. So say, for instance, you're taking out the bottle and you're going to put new water in the bottle. Not only do you clean out the bottle, not only do you clean this part here where it gets screwed back into the unit, you also want to wipe down the hose and get that slime off the that hose that goes inside the bottle, because after a while that also gets very slimy. That's that biofilm. So you take we have what's called cavi wipes that kills about everything. So you go ahead and you wipe that down, you clean it real well, and then you insert it into the fresh bottle that you will clean out. Now, chemical agents can be used to help control biofilm in two ways: periodic or shock treatments with biocidal levels that will kill microorganisms of chemicals, continuous application of chemicals to the system at a level that will kill the microorganisms but not harm human beings. So I just finished mentioning to you guys that we use chemical agents. They're like a shock for the water. We put the little tablet in there and it shocks the water, and we can use that. Now, always check with the manufacturer of the dental equipment to determine which chemical product and maintenance protocol is recommended. And then you monitor water quality in the dental unit in accordance with the manufacturer's recommendation. So the other thing is, with the little shock that we put in the water, that's another reason why we want to make sure that we get rid of the old water, because if you put new water and you forget to put a little shock inside of it, it's not going to do anything. So we got to get rid of the old water, put new water, and put a new shock every single time, or it should be done every single time we refill the bottle. Now, infection control in dental unit water, use the proper water. Again, I told you we use tap in the water unit lines, okay? We use other kind of water like distilled water, and we'll talk about that later for the autoclave. But this kind of water, we use tap water. Dental unit water should not be used as an irrigant for surgery. That was the first thing I told you guys. We don't use dental water from the unit for any type of surgery. We use sterile water. Okay. And then flushing water lines. So at the morning, I mentioned that to you already, and in between patients, we should flush the water line. So again, just running the hoses without attaching anything to it, making sure it's nice and clean, and definitely after every surgical procedure, water lines must always be flushed because you want to make sure there's no blood inside of it. Now, although this will not remove biofilms from the line, it may temporarily reduce the microbial count in the water. It will help clean the handpiece water lines of materials that may have entered from the patient's mouth. And flushing also brings a fresh supply of chlorinated water from the main water lines into the dental unit. Minimizing aerosols. So always use the high volume evacuator when using the high speed handpiece, ultrasonic scaler, and air water syringe. The high volume evacuator may also reduce exposure of the patient to these waterborne microorganisms. So the high volume evacuator, or as we call it, the HVE, is what we suction the saliva from the patient's mouth. Using protective barriers, there's something called the dental dam, and it greatly reduces direct contact. The dam also greatly reduces the aerosolization and spattering of the patient's oral microorganisms into the dental team. This is why it's important not only for us to use protective barriers, but our masks, eyewear, face shields, those serve as barriers for the dental team. So not only are we protecting the patient, we are trying to protect us. Now, the CD recommendations is to use water that meets the EPA's regulatory standards for drinking water, maintain recommended quality of dental water per manufacturer's methods, monitor water quality according to manufacturer's recommendations, discharge water and air for about 20 to 30 seconds from any device after each patient. So there you go. So when you're flushing the lines, you want to ask yourself, how long should I flush the line? Count to 20, 30 is the max. Okay, so that way you know that the lines are flush. Now, monitoring water quality. The only way to know whether the water line cleaning regimen is effective is to test the water coming out of the unit. And there's two options: using a commercial testing service by which you send samples, or you use an in-office kit. The use of saliva ejectors. So I mentioned this earlier. You can have backflow from the saliva ejector, and that's when it occurs when the pressure in the patient's mouth is less than that in the evacuator. When a patient closes his or her lips around the tip of a saliva ejector, a partial vacuum is created, and it can cause backflow to occur. This backflow is a potential source of cross-contamination. So, we use the saliva ejector to get the saliva out of the patient's mouth, but some patients want that saliva ejector like it's a lollipop and basically suck their tongue, their throat, everything. And you're like, hello, can I have that saliva ejector back? You do have your own saliva, just swallow it. It is your own saliva, So eventually, when we get into, again, like the lab, you will be doing all these hands-on, but I always want you guys to know why we are doing it. Okay, any questions with this chapter now?
No.